Good morning, everybody. Today we are going to discuss compartments of peritoneal cavity and their clinical significance. The learning objectives for my today's class are: at the end of this session, students should be able to describe division of peritoneal cavity into greater and lesser sacs, describe anatomy of the lesser sac, describe boundaries and contents of supra and infracoli compartments. They should be able to enumerate and describe subphrenic spaces, describe spread of infection in peritoneal cavity on the basis of anatomy. Peritoneum is a serous membrane that lines abdominal cavity. It has parietal layer and a visceral layer. Parietal layer lines the body wall, whereas the visceral layer lines the abdominal viscera. Peritoneal cavity lies between parietal and visceral layers of the peritoneum. It is open in females but a closed cavity in males. The potential space between the parietal and the visceral layers of the peritoneum is called peritoneal cavity. It contains only a thin film of peritoneal fluid. This fluid acts as a lubricant, enabling free movement of abdominal viscera. This cavity is divided into two sacs, the greater sac and the lesser sac. The greater sac is represented in the red line in this diagram. The lesser sac represented in blue. The communication between the two cavities is epiploic foramen. The greater sac extends from diaphragm to the pelvis. It comprises the majority of the peritoneal cavity. It forms dialysate compartment in peritoneal dialysis. The lesser sac is also known as omental bursa, is smaller and lies posterior to the stomach and lesser omentum. Before describing the omental bursa, let me ask you some questions about it. How is omental bursa formed? What are its boundaries? What is its function? What is foramen of Winslow? What is the clinical importance of lesser sac? To understand the formation of omental bursa, let us go to the development of stomach. During 4th week of development, caudal foregut begins to dilate. Initially, it is oriented in the median plane as shown in this diagram. It has an anterior border which is supported by ventral mesentery and a posterior border which is connected with the posterior abdominal wall by dorsal mesentery. Accordingly, it has right and left surfaces. Formation of omental bursa. As a result of rotation of the stomach by 90 degrees along vertical axis, anterior and the posterior borders become right and left borders, and its surfaces become anterior and posterior instead of right and left. Dorsal mesogastrium moves to the left, thus creating omental bursa posterior to the stomach and lesser omentum. So rotation of the stomach pulls the dorsal mesogastrium to the left, thereby enlarging the bursa at large recess of the peritoneal cavity. The omental bursa expands transversely and cranially and soon lies between the stomach and the posterior abdominal wall. This pouch-like bursa facilitates movements of stomach. To make things simpler, in this diagram it is shown that developing stomach is attached to the posterior abdominal wall by dorsal mesogastrium and to the anterior abdominal wall by ventral mesogastrium. It has anterior and posterior borders, right and left surfaces. With the rotation of the gut along the longitudinal axis, the dorsal mesogastrium is stretched and moves to the left. Its anterior border becomes the right and posterior border becomes the left border, and the left surface becomes the anterior surface and the right surface becomes the posterior surface of the stomach. And posterior to stomach and the lesser omentum there is creation of a bursa. This bursa we called it as omental bursa or lesser sac. So lesser sac lies posterior to the stomach and lesser omentum. It allows the stomach to move freely against structures posterior and inferior to it. The lesser and the greater sac communicate with each other through epiploic foramen. Now what is this epiploic foramen? Epiploic foramen is also called the foramen of Winslow. It is also called additus to the lesser sac. As shown in this diagram, it is slit-like opening lying posterior to free margin of the lesser omentum. Its anterior boundary is formed by the free margin of the lesser omentum. Inferior boundary is formed by first part of the duodenum. Superiorly there is caudate lobe of the liver, and posteriorly there is inferior vena cava. So it is said that the epiploic foramen lies between the two great veins. Anteriorly there is portal vein, and posteriorly there is inferior vena cava. So omental bursa is an irregular shaped recess of the peritoneal cavity that is hidden behind the lesser omentum and posterior surface of the stomach. It communicates with the greater sac only through epiploic foramen. It is also called omental bursa because the space acts as a bursa for the stomach for its expansion mobility. Fluid collection is in it displays stomach anteriorly as occurs in pseudocyst of pancreas. Boundaries or walls of the lesser sac. The lesser sac is divided into body and recesses. The main part of the body of the lesser sac presents anterior and posterior walls, left and right margins. The anterior wall of the lesser sac is formed by. To understand the formation of the anterior wall of the lesser sac, let us go to this diagram. In this diagram, I have shown that double layer fold of the peritoneum extending from liver to the stomach is called lesser omentum. This lesser omentum has an anterior layer which passes anterior to the stomach and covers it. Posterior layer between liver and the lesser curvature of the stomach form the anterior wall. So anterior wall is formed posterior layer of lesser omentum as shown in this red line, and also by the peritoneum covering the posterior surface of the stomach as shown by this blue dotted line. Both this red dotted line and blue dotted line are basically posterior layers of lesser omentum. So below the greater curvature of the stomach, black dotted line continues as the second layer of the descending part of greater omentum. Posterior wall from below upwards is formed by posterior two layers of the greater omentum and also by peritoneum covering stomach bed in the supracolic compartment. The space between second and third layer from colon to the greater curvature gets obliterated to form gastrocolic ligament as shown in this diagram. Now what is stomach bed? Structures forming stomach bed are body of the pancreas, splenic artery, left suprarenal gland, left kidney, crura of diaphragm, transverse mesocolon, and left colic flexure. The left margin of the greater omentum from below upwards is formed by left margin of the greater omentum, linorenal ligament, and gastrosplenic ligament. In contrast, right margin is formed by right margin of greater omentum below first part of the duodenum. Immediately above it is deficient due to the presence of foramen of Winslow. Recesses of the lesser sac. Lesser sac presents three recesses. They are named as superior recess, splenic recess, and inferior recess. Superior recess extends above the epiploic foramen posterior to the caudate lobe of liver. Splenic recess is basically extension of the body of lesser sac to the hilum of the spleen in between the gastrosplenic and linorenal ligaments. Inferior recess is the part extending between proximal part of the anterior two layers and posterior two layers of the greater omentum. As shown in this diagram, body of this lesser sac has anterior wall which is formed by the lesser omentum and posterior surface of the stomach, and it has a posterior wall which is formed by peritoneum lining the stomach bed. Then splenic recess lies between the gastrosplenic ligament and rhino-renal ligaments. As already discussed, inferior recess lies between the anterior two layers, we can call them as descending layers, and posterior two layers of greater omentum. The part of greater omentum between the colon and greater curvature of the stomach is obliterated to form gastrocolic ligament. thus inferior recess. What is internal hernia? A hernia is defined as protrusion of a viscous or a part of viscous through the wall of its containing cavity, whereas an internal hernia is defined as protrusion of an abdominal viscera, most commonly small bowel loop, through the peritoneal or mesenteric aperture into a compartment in the abdominal and pelvic cavity. These apertures through which hernia occurs can be congenital or acquired. In internal hernia, a loop of intestine herniates through the epiploic foramen into the omental bursa. As shown in this diagram, a loop of gut herniates through the epiploic foramen into the lesser sac. In case of strangulation, reduction of the hernia is not possible through epiploic foramen because of its important relations. The structures in the free margin of the lesser omentum are: anteriorly and to the right is CBD, anteriorly and to the left is hepatic artery, and posteriorly is portal vein. The posterior boundary of this free margin is formed by the inferior vena cava. So there, to increase the dimensions of epiploic foramen is not possible surgically. So in case of strangulation, reduction of hernia is not possible through the epiploic foramen because of its important relations. The alternate approach is through the posterior wall of the lesser sac by doing dissection along the plane of the cleavage between greater omentum and transverse mesocolon. This is in fact a bloodless plane. This plane is utilized for aspiration of the swollen intestinal loop. After this, it is easier to reduce the herniated loops back into the greater sac through epiploic foramen. Now, what is pseudocyst of pancreas? Pseudocyst of pancreas is defined as localized fluid collections in the lesser sac rich in amylase and other pancreatic enzymes that have a non-epithelialized wall consisting of fibrous and granulation tissue. The difference between pseudocyst and true cyst is pseudocyst is not lined by the epithelium, whereas the true cyst is lined by epithelium. Pseudocysts are to be distinguished from acute fluid collections, organized necrosis, and abscesses in the lesser sac. Pseudocyst is diagnosed and monitored by ultrasonography. Radiologically, it shifts the stomach anteriorly. It is drained by percutaneous drainage or cystogastrostomy. Anatomical basis: the collection of inflammatory fluid in the omental bursa may occur due to the perforation of gastric ulcer located on the posterior wall of the stomach. Post-operative fluid collections may also go from greater sac into lesser sac through epiploic foramen. Anterior wall perforations rupture into the greater sac, not in the lesser sac. Compartments of the greater sac. The greater sac is the largest portion of the peritoneal cavity. It is further divided into two compartments by transverse colon and its mesentery. The compartments are the transverse colon and its mesentery divides the greater sac into supra and infracolic compartments. Supracolic compartment lies above the transverse colon and its mesentery, whereas infracolic compartment lies below the transverse colon and its mesentery. Contents of supracolic compartment are liver, stomach, spleen, the subphrenic recesses or spaces. The words of the surgeon are pus somewhere, pus nowhere, pus under diaphragm. That means if there is pus somewhere in the abdominal cavity, giving symptoms like fever but cannot be identified by clinical examination, it must be located in subphrenic spaces. But discovery of ultrasound in 1970s has made localization of these fluid collections easy. Classification of the subphrenic spaces: these spaces are in close proximity to the liver in the supracolic compartment or of great surgical importance. They are divided into right and left subphrenic spaces. Right subphrenic spaces are further divided into right anterior intraperitoneal space, also called right subdiaphragmatic space, right posterior intraperitoneal space, also called hepatorenal pouch of Morrison, right extraperitoneal space or beer area of liver. Left subphrenic spaces are further divided into left anterior intraperitoneal space, also called left subdiaphragmatic space, left posterior intraperitoneal space, also called lesser sac, and left extraperitoneal space. Right anterior intraperitoneal space. As shown in this simple diagram, This space is bounded superiorly by superior layer of the coronary ligament, anteriorly by anterior abdominal wall, posteriorly it is bounded by anterior superior surface of the liver, and on left side it is bound by falciparum ligament. So the boundaries are superiorly superior layer of the coronary ligament, anteriorly anterior abdominal wall, posteriorly anterior superior surface of the liver, and on the left side falciparum ligament. Right posterior intraperitoneal space is very important clinically. It is also called hepatorenal pouch of Morrison or Morrison's pouch. Superiorly it is bounded by inferior layer of the coronary ligament, inferiorly by visceral surface of the right lobe of the liver, posteriorly by parietal peritoneum covering suprarenal gland and kidney. This space is very important because of its communications. To make things more clear, let us go to this diagram. It is bounded superiorly by the inferior layer of the coronary ligament, inferiorly by visceral surface of the liver, and posteriorly by the peritoneum covering the anterior surface of right kidney, as shown by this arrow. Surgical importance of Morrison's pouch. A hepatorenal pouch is the common site for post-operative abscess formation because it is most dependent part of abdominal cavity in supine position. It communicates with pelvic cavity through right paracolic gutter and lesser sac through epiploic foramen. An abscess may form secondary to the appendicitis, cholecystitis, perforated duodenal ulcer after upper abdominal surgery. Being most dependent part of abdominal cavity in supine position, this site is used to keep surgical drainage. This site is also used for evaluating post-operative or post-traumatic fluid collections. A sonographic view of the Morrison's pouch. As shown in this diagram, visceral surface of the right lobe of the liver, B represents right kidney. Between A and B, the glistening or shining line represents the peritoneum covering anterior surface of the kidney and inferior surface of the right lobe of the liver. Normally this space contains no fluid, so the interface between the kidney and the visceral surface of the liver appears shining. But in case of fluid collection, this space gets filled with the fluid as shown by these arrows. Let us identify the structures which are in this slide. Identify A, B and C. A, as already said, is the right lobe of the liver, B represents kidney, and C is the hepatorenal pouch of Morrison, which is filled with fluid. Thank you for watching this video. Also watch part second of this video entitled Compartments of Peritoneal Cavity and Their Clinical Significance, part second on YouTube. The topics described in part second are right extraperitoneal subphrenic space, left phrenic spaces, and infracolic compartment. Do not forget to like, subscribe and share this video. Do not forget to subscribe my channel. Press on the bell icon to remain updated about more video uploads.